Yeah.
I bet you I won't. I'm so excited.
So we'll just get on and if other people come, and that's fine. I'm not going to miss out too much, I think. So I'm Liz, this is Liz, and this is just on acute coronary syndrome. So we've tried just to stick to the basics and the stuff that you need to know. So obviously if you feel like you want to know something else, then ask and you can try and answer. But these exams are so really straightforward, so it's best just to concentrate on the stuff that's simple and straightforward, like what you would do, so that's what we tried to do. So firstly, just what ACS is. So the WHO defined it as having more than two of either cardiac sounding chest pain, ECG changes, so any signs of ischemia or ST elevation, or a rise in troponin I, and that's the marker that's used at the moment, but that's all changing, I think. So there are a couple of causes of it. So there's the atherosclerotic causes, which are the most common. So that's where you get formation of a plaque rupture, and then that causes platelet activation, aggregation, and then you get clot formation, and that's how you occlude the artery. There's other causes which are a lot more rare, so they're the non-atherosclerotic causes. So they're things like emboli, vasculitic causes, Prinzmetal's angina, so if you get vasospasm, also if you have sort of anemia, so the O2 demand exceeds the supply, that can cause ischemia as well. So risk factors are obviously a big thing in ACS. So the modifiable risk factors, so they're things like hypertension, diabetes, hyperlipidemia, I'm sure you know all of those, obesity, and then there's the non-modifiable ones, so age, males, family history of cardiac events, and like. So just important to ask about your history. So presentation, again, I'm sure you all know this. So it's cardiac sounding chest pain, central crushing, typically lasting more than 20 minutes, not relieved by GTM, can be associated with nausea, dyspnea, palpitations. Signs that you'd see in someone that's got ACS, it might be clammy, tachycardic, and they might have an exacerbation or new congestive heart failure. So if someone comes in sort of acutely short breath, that's why you need to check an ECG, because it could be an MI aggravating it. You might have a new pansystolic murmur. If there's papillary muscle damage, they can get new mitral regurg, so you get a pansystolic murmur. So all things that you might pick up. Differential diagnosis is important to rule out, because loads of people who have chest pain won't have ACS. So just to think about them in systems, so there's cardiovascular differentials, so things like stable angina, so angina pain occurring during exertion, pericarditis, aortic dissection, important just to rule out. Respiratory causes, so they might have had a PE, pneumonia, pneumothorax, so again, just rule them out. GORD is esophageal reflux disease, obviously a massive one. Esophagitis, alcoholic gastritis, peptic ulcer disease, gallstones, pancreatitis, and then musculoskeletal, so if someone's been lifting boxes the day before, or acoustic chondritis, they might have cancer and have bone mets, so that can all cause central chest pain and need to just be ruled out. So the things that you'd use to diagnose it, ECG, obviously, and then cardiac enzyme, so the one that's used in these at the moment is a 12-hour trot, but people always also talk about CKMB, which is just creatine kinase that's cardiac muscle specific, but that's not used routinely. What we use is the 12-hour trot. So STEMI versus non-STEMI. So they're just the two types. So to diagnose a STEMI, it's got to be an ST elevation it's got to be of higher than 1 millimetre in 2 consecutive limb leads, or more than 2 millimetres in the chest leads. You might have reciprocal changes, so they're just in the opposite leads. Another criteria for a STEMI is a new left bundle branch block, and also important to not miss the posterior MI, so that's when you have ST depression in 1, 2 and 3. I have a peak T, V2 and a tall wide R wave, although the main thing is just the ST depression in 1, 2 and 3 can be a posterior STEMI instead of a non-STEMI. So non-STEMI is when you don't have the ECG changes that you get in a STEMI, but you might have these just general ischemic ECG changes, so a bit of ST depression, a bit of T-wave inversion, so just sort of non-specific ischemic changes. But the thing that separates non-STEMI from unstable angina is the fact that you've got a rise in troponin, so you have to have a significant rise in troponin after 12 hours, and that confirms that it's a non-STEMI. And then if you don't have a rise in troponin, that's when it's just unstable angina, so that's just cardiac chest pain, lasting more than 20 minutes, at rest, not aggravated by exertion. There may still be the ischemic changes that you get with the non-STEMI, but there won't be the rise in the troponin. So these, I didn't put on the ischemic changes because they're a bit non-specific, and I thought you can generally see a little bit of T-wave inversion and just compare it to old ECGs and see whether or not it's new, or if you're not sure what it is, do another ECG a little bit later and see whether or not the changes are progressing. But this is the one that I'm sure will come up in your exam at some point, which is the STEMI, which you just don't want to miss. So you can see that there's the ST elevation there pretty much in all of the chest leads, and it's quite marked. There's progression in ST elevated MIs as well with the ECG changes. So the ECG that you get will depend on how far through the MI it is. So that's what I've got at the bottom there. So I don't know if you can see the labels or if it's a little bit far down. But there's the first one, which is normal, and then minutes to hours you start to get a hyperacute T wave. Between 0 to 12 hours you get the ST elevation. The Q wave starts developing between 1 and 12 hours. You get inversion of the T waves after 2 to 5 days, and then the T waves eventually recover. Well, in most people will recover in weeks to months. These are just the territories, so you know sort of where the infarct is, what arteries affected. So septals generally 1 and 2, and then the anterior leads 3 and 4, lateral 5 and 6. Those. That just says the reciprocal leads on the second slide, so if you're really bothered about which artery it is, you can read that at a later date. And then the posterior is 7, 8 and 9.
Okay, so for the initial management, like Lizzie said, we're trying to do this with what you would do for this patient as they come in your class here. So obviously you want to do the A, B, C, D, E approach and sort of fix those before you move on. So what you want to do in ACS is sit the patient up. That just helps them to breathe and sort of alleviate the pain. You put 15 litres of high flow oxygen on through a non-rebreathe mask, and then you ask the nurse for observations and get an ECG right at that stage, because it might not be ACS, so you don't know what you're dealing with until you have the ECG. And you just need to take a brief history and exam just to confirm the diagnosis as well. Obviously, if you've got massive ECG changes, you're pretty sure it's going to be ACS, but you need to know a little bit more about the patient. And then you need to get IV access and bloods. So for full blood count, you're looking for things such as anemia, which could have brought the ACS on. You want to check their user needs, because obviously imbalances of electrolytes such as potassium can bring on MIs. You want to check their CRP in case there's an infection, and then at a later date you want to do a 12-hour TROP. You want to do a fasting glucose in case they have diabetes, and you also want to check their cholesterol in case, especially in a young patient, they might have a cholesterol disorder. And you also want to check their bleeding risk before you give them treatment such as heparin.
This is just all about the glucose is in the GRACE score as well, which we'll come on to later. So all is if you do sort of your initial test, it's all part of predicting outcome and predicting sort of risk of further events and mortality and things. So it's just one of those to stick on if you've got time.
Okay, and I'm sure you've all heard of MONA by now. So morphine, you want to give them to alleviate the pain and to help their breathing. So you want to give them 5 to 10 milligrams IV, depending on the weight of the patient. So obviously if it's a big ginormous man, you can probably be safe giving them 10, but if it's a tiny little old lady, maybe 2.5 to 5 would be better. You said the oxygen, you want to give them nitrite, so 2 plus per GTN, and you can give that every 5 minutes, and that should help the pain. You want to give them aspirin 300 milligrams, and they chew it, or you can give it to them dispersed in a drink, and you want to give that straight away. And then if you've checked their BMs and they're high, then you want to put them on a sliding scale. So in a STEMI and an NSTEMI, there are different treatments, as I'm sure you're aware. With a STEMI, you give them heparin and take them straight to primary PCI if it is available, or you can thrombolyse. In LGI and St James's, we go straight for PCI, so it's always something you should mention in the exam, because that's where your exams are. And otherwise they can be transferred from the districts nowadays anyway.
Yeah, generally most people come to our drive that have a STEMI, they'll be here pretty quickly if it's within office hours.
Yeah, so they normally, the ambulance sort of picks them up and they come here anyway. So most patients in Yorkshire do go to a PCI centre, and then you give them 300 milligrams of clopidogrel stat dose as well.
And there are some sort of like more in-depth rules to that as to who goes for PCI and exactly what drugs they give and what dosage and things that changes, but you won't need to know that, so it's just sort of a basic overview of the differences between the two.
Yeah, and obviously you'd have phoned your registrar or phoned someone involved in this patient, so you want to do the first, sort of the MONA first, and get a nurse to ring your registrar and tell them what's going on, and then, you know, you're not just going to send them to PCI yourself, you're going to involve other people in the care. In an NSTEMI it's slightly different, so they get given heparin and then they go for angiography plus minus PCI at a later date really. So the STEMIs go straight in. As soon as they get in the ambulance, they've phoned the doctor and they're going straight for PCI as soon as they arrive in hospital, whereas the NSTEMIs tend to get PCI within 48 hours really.
And it all goes by their GRACE score, so if they've got a high GRACE score, it's all, I don't know, it's all like target driven, but it's between 48 and 96 hours. So if they've got a high GRACE score, so they're at high risk of mortality, which we'll go on to in a minute, they will get a PCI, well, angiography plus or minus PCI over that 48 hours, whereas other people might just come back and be seen in clinic and only be seen in angiography if they've had recurrent episodes of chest pain or other episodes.
And the reason it's done that way is because patients who have a STEMI are at higher mortality, so that's why they need the PCI straight away. But the angiography plus minus PCI at NSTEMI patients tends to be better because it's more controlled and they're more stable. So that's why if you can wait, you should. But in STEMI patients, it's proven that it's sort of high morbidity if you leave it.
So do you not give clopidogrel for non-STEMI?
This is the
not
GRACE
until
score.
they're going for the PCI. So
It
you give it
depends
to
on their
them
risk
later.
again.
You don't necessarily give it straight away. But
So you do their GRACE score, which you can get on like MedCalc and stuff. I think it's the one that's used in the NICE guidelines, and it's the one that's used most often, I think. But there's loads of like validated risk scores that are based on loads of different risk factors. So the GRACE score assesses the 6-month mortality and also the risk of subsequent MI following episode of non-STEMI or unstable angina. So it just takes into account, you can just type in all the values and their blood pressure and all of this stuff. And it takes into account their age, whether they've had previous MI, their comorbidities, whether they've had previous PCI, previous bypasses, their BP, heart rate or oxygen, their ECG results, their blood results, including their glucose and lipids, and there's loads of things on it. There's also like whether they came in cardiac arrest, which is obviously going to be a poor outcome indicator, so I don't know why that's on it.
you don't need to know like the specifics of GRACE score. It's just so you're aware of that there is a sort of a validating score for patients who come in with NSTEMI. And there's also the TIMI score, which is very similar, and that does the risk assessment for STEMI and NSTEMI patients. But realistically, in real life, what you're going to be doing is you're going to be getting your registrar involved and the cardiology registrar involved, and they're going to decide. You're not going to be the one calculating the GRACE score and saying, I want this patient to go for PCI. But it's just so you're aware of what type of things you need to know in the history. And what
that
sort of
bit at the
science you
bottom
check
is,
for.
that's just like, as I knew someone would say, what about clopidogrel in non-STEMI? So it's just, you wouldn't need to know that, but it's just to show if they're really low risk, they're just conservative, they don't need clopidogrel, and then as the risk goes up, they have clopidogrel and then maybe PCI angiography.
Okay, so after they've gone, this is for patients who've actually been revascularised. Not every patient will be revascularised. So they need to have 48 hours bed rest with continuous cardiac monitoring. Hopefully they will be on a cardiology ward, so then that's very easy and they just get hooked up to the machines and the nurses monitor them. They also need to be given low molecular weight heparin for about normally 2 to 3 days, and then they can be discharged after 5 to 7 days. You need to tell the patient that there's no driving or intercourse for 1 month. And obviously you need to find out what the patient does for a living, because if he's a truck driver or a bus driver, anything like that is really going to affect his life. The lorry drivers can't ever do it again.
Yeah, there's real strict rules for HGV drivers, so it's really important to ask in your history.
And that's something they might catch you out in your OSCE with if you haven't asked.
So it's good to get into the habit of as well, because it always bites in the ass when you're going for that certificate and there's no occupation anywhere, and it's just such an easy question.
So they will all have outpatient follow-up within 5 weeks and 3 months, and normally most of them will get an echo to check their LV function, because that can be disrupted, especially after a STEMI, and then ECG to assess for branch block, which might be new. So secondary prevention. I'm sure you're all sick to death of hearing about things like this, but it does come up time and time again in the exam and the OSCE, and it's just really easy marks. So secondary prevention, you want them to see a cardiac rehab nurse and they go through everything with the patient. So doing sort of what they can and can't do in sort of the days, weeks, months to follow after they've had the MI. And then you want to talk to them about the modifiable risk factors in their lives that they can change. It's a massive one, smoking. So you really need to talk to them about smoking and get right on their discharge note so that their GP follows it up. You need weight loss and exercise. You need them to have a better diet, so low salt, low fat, reduce their alcohol intake, and do the tight diabetic control. That's why it's really important after patients have had an MI. They should all go home with a cholesterol reading and a fasting glucose. It's really, really bad if they don't, because the reason they might have had the MI is because of these modifiable risk factors, and we wouldn't know what they are if we haven't done the simple test. So that goes down to you. That's a very F1 job.
It's also like pharmaceutical management as well. So there's like a list of drugs that everyone goes home on. So statin and low cholesterol. So everyone goes on that, just regardless of their cholesterol level. Everyone goes home on statin. Lifelong aspirin for 75 milligrams daily. Clopidogrel 75 milligrams daily for a year. Beta blocker is shown to improve outcomes, so everyone is on one of those. And then type blood pressure control with an ACE inhibitor or an angiotensin receptor blocker if there's contraindications as well.
That's a really common OSCE station, by the way, is to go through sort of each of the ACS medications with the patient, sort of saying what each of them does and why they're on it and why it's important that they're on each separate one. Okay, so complications. The list is on your arm for complications after MI. The main ones, sort of really serious, cardiac arrest or cardiogenic shock, and they tend to happen pretty early on in their sort of presentation. You can also get brady or tachyarrhythmias. That's why they need sort of such tight cardiac monitoring. The big one is the congestive heart failure. So if a patient becomes short of breath after they've had an MI, it's really important to get a chest X-ray when they come in. And also, if you notice that they're short of breath on the ward later on, they can get pericarditis, and it's called Dressler's syndrome once it's secondary to pericarditis following an MI, and they tend to be when it's a large anterior MI. You can get mural thrombus, you can get valve defects, especially mitral regurg, as Lizzie said before. You can get septal defects, and you can also get aneurysms. So there's a big list, and patients don't necessarily need to know every single one. It's just so that you're aware of what you should be looking out for in patients after they've had an MI. Okay. So we've also done some little slideshow things for you because we thought it's a bit more interactive, and you probably know ACS quite well. So these are just some pictures which could come up in the slideshow, and just so you're aware. So I'm just going to show you one, write down the answer, and then you can see the answers afterwards. Okay? And be specific in the slideshow. Okay. Okay. So, I'm sorry, I've not actually written the first part of that. So it shows, what do you think it shows? Someone shout out. Wonderful. Okay. So all wrote, you need to write the inferior part, because that would be a 2-mark question in the slideshow probably. So this is just, it's an extension of Mona, so it's Mona Lisa. So I hope you all wrote down Mona, so give morphine, oxygen, nitrites, aspirin, and then these are just some extra bits. So if you think they're short of breath, you can give them diuretic. You need to get IV access and take bloods from them, and you need to be specific, so use needs, HB, blah blah blah. Streptokinase you're not going to be giving, but it's just something you can be aware of. And then you need to give them antiplatelets, such as clopidogrel, and then involve routine early on, because it could be a very sick patient. So it's not just you're handling this completely on your own. Is that alright? Okay. So what do you think this lovely man is? What's wrong with him? Breaking Bad, yeah. It's not Walt from Breaking Bad, no. Okay. Okay. So as you can probably tell, I like my little acronyms because it helps me learn them. So I do COBRA A. So she'll go home on critical. I ignored the omega-3, it's a weird one. But bisoprolol, ramipril, aspirin, and atorvastatin. Also, most patients, if you put them on the aspirin and the clopidogrel, most patients do actually go home on a PPI, so they go home on lansoprazole as well. So it's just a little extra thing. If you can remember it, you'll look quite slick in the exam if you just write that down as well, because they should all be on it.
I think we had a question as well about which one improves outcome, because I think it's only bisoprolol that's actually been shown to improve like long-term survival and outcome, isn't it? The beta blocker and the ACE inhibitor are the only ones that are actually shown to improve survival, but they're going on a little bit because obviously short-term outcome is just as important.
Okay.
What does it show?
What does it show? Anyone? Do you not know? Yeah? Pulmonary edema? There you go.
Sorry,
Okay,
I just didn't want to be the one.
No, that's fine. Okay, so this is really common after patients come in with a STEMI. Why?
Left ventricular
Yeah. Yeah, left ventricular failure. So then they go into massive pulmonary edema and are really, really sick. Okay, so other causes of it.
Fluid
Mm.
pulmonary hypertension, pulmonary.
Okay, so for this purpose is cardiogenic LVF after MI. The main ones are acute lung injury and acute respiratory distress syndrome. That's why a lot of patients end up in ICU. Anything airway obstruction causes pulmonary edema. Neurogenic causes such as seizures or head traumas can.
Low albumin.
Yeah. And last one, label the diagram of a chest X-ray and left ventricular failure.
They're just like 3 things that you just say even if you can't see them.
5 things.
5 things.
What?
Oh yeah.
You know. She does know.
Counted it 3 hours and actually it's got it.
Yeah. And again, there's a nice little acronym that you can remember.
Someone done?
So A, B, C, D, E. So it's nice and easy. So you've got alveolar edema, you've got curly B lines, cardiomegaly, the dilated upper lobe vessels, and then effusions at the bottom. So if you can just say, it's quite easy to remember A, B, C, D, E, and it is a question that does come up again in OSCEs and in the written exam. That's it.
Does anyone have any questions? Sorry, that was really quick, just because we've only got half an hour, so we sort of spent through it quite quickly.
In a STEMI, do you get funded RNS or not?
Fractionated.
Yeah.
Depends what trust you're in. The nice guidelines just says whether it's unfractionated or not RNS. I don't know, what does it do?
We give funded RNS, so 2.5 milligrams.
Okay.
It just depends. All those like heparin things, it all just depends on what the trust likes and
And what the consultant likes.
What the
Some of them
consultant
like 2 days, some like 5 days. It kind of varies, but you know.
the same with all like prophylaxis and stuff. Different trusts use different things. I think it just depends who they want to deal with and what's cheap.
I think as long as you're aware of the basics of it, and if you can justify why you're giving it, then you'll be fine. And by the way, the slideshow is definitely the worst exam, so get into the routine of doing things like that, because a minute silence on your own is hard.
I remember Kate coming home
Yeah, it doesn't.
like,
Genuinely, it doesn't happen
Yeah.
that much anymore, really. There's a lot of places.
Where
Most
PCR
places have somewhere
like,
close
you
enough
see
that
quick guys,
does
you
primary
know what your
PCR,
dog,
so
like, let alone the other.
even if the hospital that they're in is like DGH, most people can get to you know, tertiary centre to do it, so it doesn't really happen very
And some people did quite similar. Yes, but my group